Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from April the 3rd to the 10th. Here's the overview. On April the 3rd, the American Association for the Surgery of Trauma released consensus guideline focused on post-intensive care syndrome, or PICS. A newly emphasized domain, persistent thromboinflammatory dysregulation and sustained organ dysfunction, referring to maladaptive immune thrombotic activation and ongoing organ failure after discharge, previously called persistent inflammation, immunosuppression, and catabolism syndrome, now integrated into the broader post-intensive care syndrome framework. The guideline recommends performing functional reconciliation, compare post-ICU function to pre-ICU baseline, before discharge, screen all ICU patients with length of stay more than 48 hours, and when a formal PICS clinic is not feasible, integrate PICS assessments into existing outpatient clinics and educate inpatient or outpatient providers. Next, on April the 3rd, the International Association for the Study of Lung Cancer released the consensus statement of definitive radiotherapy to the primary tumor in stage 4 non-small cell lung cancer. Traditionally, radiotherapy in metastatic non-small cell lung cancer has been reserved for palliation, but emerging evidence suggested that radical radiotherapy to the primary tumor may improve outcomes, particularly in EGFR mutant oligometastatic disease. The statement also synthesizes randomized evidence from 2010 to 2025 and provides expert consensus on timing, dose, target volumes, and safety. For timing, early radiotherapy as consolidation after induction systemic therapy is promising, especially in patients with actionable genomic alterations. For dose, higher doses, for example, 63 grays versus 45 grays, improve local regional control and possibly overall survival, though with increased toxicity. For target volumes, omitting involved lymph nodes may preserve immune function and enhance immune therapy efficacy, but this remains unproven in prospective trials. For safety, toxicity is generally additive when radiotherapy is combined with systemic therapies like TKIs, immune therapy, or chemo. Not synergistically amplified, but caution is needed with dual immune therapy or large volume radiotherapy. Then on April the 6th, the European Society of Cardiology and the American College of Cardiology jointly released a clinical consensus statement on Masters athletes with abnormal cardiovascular findings. Masters athletes is defined as age over 35 years with exercise habits consistently exceeding public health recommendations, who is driven by performance goals rather than health goals. It includes runners, cyclists, triathletes, rowers, and former elite athletes. Evidence shows that higher prevalence of certain cardiovascular abnormalities, including atrial fibrillation, bradyarrhythmias, premature ventricular contractions, coronary atherosclerosis, aortic dilatation, myocardial fibrosis, and exercise-induced arrhythmogenic cardiomyopathy are seen in this population. Unique clinical challenges like symptoms may be atypical and resistance to medications require shared decision-making that respects the athlete's goals while applying evidence-based cardiovascular risk reduction. However, no randomized controlled trials in athletes have been performed, and mechanisms linking exercise to atherosclerosis, fibrosis, and aortopathy remain incompletely understood. Move on to new FDA approvals. On April the 7th, The US FDA approved the first generics of dapagliflozin tablets with the same contraindications, warnings, and precautions as Farxiga. Last but not least, let's talk about obesity. On April the 6th, the World Obesity Federation released a position statement on the role of physical activity in the prevention and management of obesity. Obesity is not simply about willpower. It's a complex, chronic disease shaped by genes, environment, job, stress, and community. And the old advice to just eat less, move more, isn't just unhelpful, it can actually cause harm by adding shame. So what is the right thing to say about physical activity to obesity patients? First, movement is essential, not because it will make you thin overnight, but because it makes you healthy. Regular physical activity lowers blood pressure, improves blood sugar, reduces inflammation, boosts mood, and protects brain. Even if weight doesn't change dramatically, you can become metabolically much healthier. Second, if you're taking a GLP-1 agonist, physical activity, especially resistance training, like lifting light weights or using resistance bands, is critical to prevent muscle loss. Third, don't let perfection get in the way. Any activity is better than none. Walking counts, gardening counts, taking the stairs counts. Start where you are, not where you think you should be. And finally, recognize that barriers like pain, fatigue, embarrassment, lack of safe places to walk are real. Good policies and supportive communities should be helping along the way, and individual preferences with low-impact, accessible options are favored in management plan. That's all for today. Enjoy your weekend and see you next week.